now. This way, hopefully we'll be able to get this up onto the website, and we'll be able to, sorry, we're having some, Microsoft makes things easy and difficult all at the same time. It's kind of amazing. I always forget to shut off the lobby feature. So we are recording this so we can put it up on the Perinatal webpage like we did for the other ones. We moved to this format so we didn't have to deal with the issues with GoToWebinar that we had been having. So if someone could give me a thumbs up if you could see the slide screen. If anyone wants to do that, if you're looking at a PowerPoint slide right now. Anybody? All right, good stuff. Yes. This meeting is going to be a little bit different in that instead of kind of making it didactic and going through just slide after slide, what we're doing is we're going to be presenting you with a new tool, and then we're going to be presenting a new tool for everybody to use, and then we're going to go through a scenario, kind of walk through a case, so that we have the ability to kind of troubleshoot some things that maybe snag people from time to time or cause confusion, and where to document things in the cases and things like that. If you have questions, we're going to hold them to the end, and we will have plenty of time. But if you want to put questions in the chat while we're going through things, so if you're thinking of something you want to ask a question, by all means, put it in the chat, and we'll get to it at the end as well. I did send out two attachments a little bit earlier. One was the Perinatal Hepatitis B checklist for investigators, and the other one was the scenario. So if you don't have those, I can also drop those into the chat real quick if the computer will let me do anything quickly, and we can get that to you. Hold on one second. All right, so I'm going to throw these into the chat if it'll let me, and then we'll get started. It will not let me. Okay, so if you didn't get them, you'll see them on the screen, and then we'll send them out again at the end. So what I'm going to do now is I'm going to share the checklist. So this is a new tool that we developed and I'm so sorry. Hold on one second. My apologies for this coming up weird. Let me, we're using a common computer as opposed to, what do you call it? As opposed to our personal computers. So it's, sorry, my apologies. I will try to open it in PDF really quickly, but essentially what we did was we wanted to really set up a checklist for use by our investigators that will assist you in knowing like all the different parts of what goes into a case investigation and where those cases should be followed up. So I'm sharing. Let me make sure that I'm sharing the appropriate screen, and it it appears that I am. We're still admitting people, so everybody's coming in drips and drabs. So with this checklist, we're gonna just roll through it really quickly. Essentially what it does is it starts with the mother's case and then it works its way through to the infant's case. So for those of you that have been doing case investigations for some time, you know that the vast majority of our cases should always start with a pregnant mom. So we have said for a few years now that all women age 15 to 55 are what we consider to be women of childbearing age. And if a woman is of childbearing age and has a new hepatitis B lab, pregnancy status should be current for those labs. We've also always said that if you are working with cases and you know that those cases are getting tested on a regular basis, whether that be, if they're in a clinical trial, if they're just starting medication for hepatitis B, if they are in dialysis, if you know that they're going to be tested, let's say every month, or for whatever reason have like new viral load labs coming in frequently, you can always work with those cases to check in with them less than every new lab. But you have to make sure that you're checking with them at least quarterly, just to make sure that, if their pregnancy status changes, even if they say to you, listen, I'm not having children, in the exception of someone who, literally cannot have children. So if they have a prior, history of hysterectomy or something of that nature, if there's gender issues, if they are, a transgendered individual or someone who identifies as a woman but biologically is not a woman, that might be a sensitive topic. Those types of things, you really need to get these pregnancy statuses. So you can see on the checklist that it starts with the mom, and it will ask you to get that pregnancy status for that individual. For pregnant women, you always want to, if a woman says that they're pregnant, you want to make sure that you get the estimated due date and the possible expected delivery site. So a lot of people know where they're planning on delivering. They don't always deliver there, but at least it's a piece of information that we have, that if we have to go tracking things down, we have at least a jumping off point. Also, when you obtain pregnancy status, just know that the status is that they're pregnant. That status can change from when they talk to you at one point to another. So we do unfortunately have to deal with situations of pregnancy loss. Those are very sensitive topics, pregnancy terminations, things like that. Those are all items that can be logged into CDRSS so that we know what's going on. It can be, like I said, a sensitive topic or a difficult conversation to have. And if you guys need any tips or tricks with how to discuss those topics, we're certainly here to work with you. This just came up on our quarterly call with CDC, where some new coordinators were asking about different ways to deal with that. So just know that if you have those questions, other people have those questions as well, and they're not easy topics. So we certainly can work with you on that. For all live births, so you're going to have to document in the mom's case whether or not when they gave birth, and then you have to document the baby in the mother's case as well. So I think one thing that we see is sometimes we have investigators that will create a case for the baby outside of and separate from the mother's case, which they are in CDRSS. It's a person-based system, so the child has its own case, its own person ID, but we can link cases. And the easiest way, and one of the reasons we wanted to go through the scenario today, is to show you how you can easily link those cases from the moment you create the infant's case. And that way we know that there is actually a baby that is associated with that. Because sometimes what will happen is we'll go into a woman's case and we'll see that she was pregnant, we'll see that you documented she gave birth, and then we don't see a record for the baby. And we have no idea because not all babies have the mother's last name. Not all, we might not be able to specifically decipher whether, baby Smith is Jane Smith's baby or Sarah Smith's baby. So we need to make sure they're linked so that we aren't, coming for you guys and asking you, like, you said this person had a baby and you're like, I've been following this case for a year, and you're like, oh, okay, my bad. So we want you to get the credit, and then that way it also helps us so that we don't annoy you unnecessarily. It's really the nicest way to put it, because we're really not here to annoy anybody if we don't have to. So as you can see, as you scroll down this list, it kind of transitions from the mother to the child. And what you'll notice is once you create the infant's case, you can actually just close out the mom's case. You're kind of done with the mom's case at that point. The mother's case does not need to remain open unless you're waiting for more information. I mean, if for some reason you're waiting for additional information on the mom, you're trying to, find out that the mother is a confirmed chronic case or something like that, you don't have to close the case. But once the baby's born, you can close that case out, but it will reopen if that woman gets tested again for whatever reason. And unless she has a baby at 54 and a half, and then, the next time you see it, it's, 56 years old, we probably have to go back to her and be like, another congratulations, yes or no? When you go into the child's case, just know that the kid's case can remain open for up to 2 years. So making sure that you're documenting all of this is really important, and you want to do it expeditiously. But if you kind of come up against a wall where you're like, the parents aren't getting back to us, we're having no luck, we will ask that you keep the cases open, because there are other avenues to find information, such as looking in the immunization registry. They might have updated contact information, things like that. But we really want to make sure that we're always doing our due diligence in trying to get the full complement of information that is required by CDC for all of these cases. There are perinatal questions in CDRSS in a separate tab. You need to fill out those questions. So one thing that you guys might not be familiar with if you haven't been around for a long time, but I'm sure we've mentioned it in the past, is the data you give us is then analyzed and summarized and sent to the CDC. So unlike your regular caseload, where case counts go to CDC, this disease is its own program. And in that program, we summarize our data by birth cohort every year in an annual report for CDC. And that annual report is due at the end of March for us, which means we would really love for your cases for the birth cohorts that are being reported that year to also be as complete as possible by March 30. Well, really you need to, it would be lovely if they were completed by the end of February, but no later than like March 15th. And that's because we have to get our reports in, and we want you guys to get all the credit that you deserve for the hard work that you're doing. And that always happens by us, showing them that our data is as complete as possible. So it is very important that you fill out the perinatal Hep B questions in CDRSS, and you should fill those out along the way, right? So when you first have the kid and the child's born, you're going to get, the birth weight, you're going to get their insurance status, their first dose of Hep B and their HBIG, birth weight, those types of things. That you're going to get all of that at birth. You might as well document it at birth. A lot of people like to put these types of things into comments, and then it gets lost and it can't be analyzed, right? It's like when you fill out a survey, the data that gets analyzed is the ones where you can check, you know, a number on a scale or put in specific answers. As much as your narrative will tell us what's going on, we can't pull that data from the case and analyze it like we need to send to CDC. So as the child ages through the Hep B schedule, depending on the type of vaccine that's being used by the physician, depending on the child's birth weight, that child will get anywhere between 3 and 4 doses of hepatitis B vaccine. And you need to document that in CDRSS. You get that information, it should be in NJIS, but I think most of you know it's not always, or maybe is not commonly in NJIS. And that's why it's important to have a relationship with either your local physicians or the parents of these children to make sure that you have access and the availability of the information that you need. Once you document the child has gotten all of their hepatitis B doses, that's when they're ready for their post-vaccination serologic testing, or PVST. So as investigators, I'm sure you're used to having labs come in passively to CDRSS when you have cases of disease, but perinatal Hep B is a little bit different because what we're looking for, our outcome that we're looking for is actually not disease, right? Our outcome is hopefully that this baby did not get infected because of all of the measures that were taken to protect this child from the time that it was born. So generally the labs that will come in for us are the labs that will come in for us is, you know, usually negative, right? Your surface antigen is generally, if our job has been done correctly or if the science has worked, that'll be negative. And as we know, we don't get negative hepatitis B labs yet into CDRSS. So this might be something you have to go after. So you might get a positive surface antibody or a surface antibody level that comes in because the doctor ordered the lab and it's positive, and we have that coming in for kids of this age. But you need to make sure that you're also documenting that surface antigen, because PVST is a 2-test panel that should be done in a very specific way at a very specific time. So we need to be sure that we are getting all the information we need, and then we're working through it to make sure that the lab results, you know, basically the lab results will dictate what our next steps will be. And like I said, we'll go through that as well. Oh, yeah, you gotta go the opposite way right now. I tried to change it, it didn't work. I'm so sorry, guys. My apologies. So we're on PVST now. I'm trying to admit people and talk, and it's just, it's amazing what the brain can do. So this right here is showing you the different outcomes, right? So children are generally either going to be immune and non-infected, and that's the vast majority of the people we actually get PVST for. And just to kind of let you guys know, our numbers are not great. So we want to make sure that, you know, we're working towards maybe, you know, getting kids to complete these tests. An infected individual, which we haven't had in a long time, which is great. An infected individual would fall into the category as seen here. And then here is where we get into the situation where if a kid isn't infected but doesn't show an immune response, it's going to be some revaccination, and we can go through that at the end if anybody has any questions about that. But there's a link right here that takes you to the most up-to-date information for people with hepatitis B, and specifically discusses what happens to kids who don't respond after the first dose. The third page of the checklist is simply additional resources just for you to have to be able to quickly get to